advanced ART masterclass. So today's topic is going to be from genes to generations, the role of genetics in infertility. So as you all know, we have two masterclasses every month, one embryology masterclass and one advanced ART masterclass. So usually the first and second week we have embryology masterclass, and the last week we'll have on Thursdays 7:30 to 8:30 p.m. we'll have our advanced ART masterclass, and we have excellent speakers lined up. And I'd also like to inform you that we're starting our scale fellowship programs, 1-year fellowship program in clinical embryology and 1-year fellowship program in ART. So whoever is interested can contact the below number or can contact Vasundara ma'am. So with that, I'd like to invite Vasundara ma'am to invite our speaker for today.
Good evening, one and all. It gives me a great pleasure and privilege to invite Dr. Fiona. She is well known among the field of reproductive medicine and genetics. She is heading the scientific operations at the Department of Clinical Genetics at Anderson Diagnostic Services Private Limited. She is a prestigious PhD holder, clinical embryology and pre-implantation genetics from Manipal Academy of Higher Education. She's a certified program in genetic testing and sequencing technology from Harvard Medical School. Her present role includes management and development of diagnostic investigations in clinical genetics, development of personalized diagnostic plans for patients with genetic disorders, academic and social campaigns on developing awareness on genetic disorders and current diagnostic solutions available. Very interesting. She's got affiliations to prestigious organizations like ESHRE, ISAR, IFS, and also member of IFS Special Interest Group Applied Genetics. And her area of special interest include reproductive genomics, endometrial receptivity testing, prenatal genetic diagnosis, clinical embryology, and assisted reproductive technology. So with this, brief introduction about Fiona, I would also, extend my great pleasure to welcome her to give a talk on genetics and infertility. In the recent years, we all know genetics has emerged as a powerful tool in understanding the root cause of infertility, and from identifying inherited conditions that can affect fertility, we are moving on to uncovering genetic factors that can lead to recurrent implantation failure or recurrent pregnancy losses. Or, the field is advancing and transforming leaps and bounds. So today's talk will definitely shed light on how genetic testing and counseling can guide personalized treatment, improve our patients' outcomes, also a few discussions on prenatal genetics, and how we can make appropriate reproductive choices. And I'm extremely delighted to invite Dr. Fiona to, continue her talk, and we will be privileged. All of you, please do interact with her and gain the maximum out of this lecture. Thank you so much.
Thank you for that warm invitation and introduction, ma'am. So I'll not take much time. I'll just start off right away. Is my screen visible? Yeah, am I audible, ma'am?
Yes.
Yes. So today we are going to discuss on what is the role of genetics in infertility. So we're going to go through basics and then understand how genetics is applied in reproductive genetics, reproductive medicine, and how we use this tool to prevent genetic conditions in the next generation. So my lecture is divided into 4 main parts. One is the essentials of reproductive genetics. So we'll go a little through the basics. Second most important part is carrier screening. How do we identify and diagnose the genetic disorders in symptomatic and asymptomatic people? And then we go through clinical interventions possible for genetic disorders, how and when we choose which option. And finally, the genetics of male and female infertility. So basically, our body is made of trillions of cells, and each of these cells hold inside it the nucleus, which contains our genetic material. Now, the genetic material is basically like a ball of DNA, and this DNA is subdivided into chromosomes. If you open the chromosomes, that typical double strand of DNA is seen, and this basically has the genetic code embedded inside it. Okay. So when we run investigations on the genome, it is done on two main stages and then the expression of the genome. So to look at the genetic signature, we do DNA sequencing, which is a stable entity. So from the time we are born till the time we die, there are minimum amount of changes on the DNA that happens. Next is RNA. This is the most volatile version of the genome. This is how the genome expresses itself. So DNA is transcribed into RNA, and RNA expression, RNA is basically the expression of DNA, so it changes from time to time. Does not remain stable. So if you do the test today and you do the test tomorrow, a physiological condition can cause changes on the RNA. Then finally is the proteins. Now, the proteins are more volatile than the RNA. They keep changing more frequently than the RNA transcription. Okay. Now, when we come to investigations of the DNA, the main investigations happen at the chromosome level. So as I said, DNA is divided into 46 chromosomes. These are basically 23 pairs. They're numbered from 1 to 22 based on their size, and they have typical banding patterns which are used to identify these chromosomes, and we can also identify when they switch their locations. Now, women have 2 X chromosomes, men have 1 X and 1 Y chromosomes. So what are the new changes that can happen? The most common change that can happen on the chromosomal complement are numerical chromosomal changes. Now, if this change happens at a one particular chromosome, it's called a trisomy if it occurs in 3 copies. If there is loss of one chromosome, it becomes a monosomy. So instead of 2, we have only 1. So these are aneuploidies, chromosome number changes. Another version of the chromosome number changes is called triploidy. These are ploidy changes, which means our entire genome is in a diploid state. That means 2 copies of each chromosome. In case we have only 1 copy, it's called haploid. These pregnancies are not compatible with life. We tend to see this more in IVF. We would not come to know this in natural pregnancies. The diploid is the natural normal state. Then you have triploid and tetraploid. Triploid meaning all 3 copies, all the chromosomes are in 3 copies, and tetraploid means all the chromosomes are in 4 copies. Now, the most common type of trisomies we get to see are the trisomies in chromosome 13, 18, and 21, which is Down syndrome, Edwards syndrome, and Patau syndrome, respectively. Trisomies are not restricted to these 3 chromosomes. They can happen on any of the chromosomes. Why these 3 chromosomes are important is because these 3 chromosome trisomies are compatible with life. All other chromosome trisomies end up in the first trimester miscarriages, and therefore the pregnancy does not progress beyond the first trimester. It's extremely rare for it to continue further. But these 3 chromosome changes are compatible with life, and the changes can be so subtle that it may not express itself as a phenotype. That means the routine imaging of the fetus during pregnancy cannot detect these chromosomal changes. That's why these 3 chromosomes are important. The next 2 chromosomes which are important that do not show any imaging related manifestations are the sex chromosome aneuploidies. This can mainly be Turner syndrome, very common monosomy. It is called monosomy X when the second copy of the sex chromosome is missing. They could be Klinefelter syndrome when we have 1 extra copy of the X chromosome. So this XY. These are males with lack of secondary sexual characteristics, gynecomastia, etc. They suffer from infertility. Then is triple X syndrome. These individuals are almost normal, they have a little bit of height and some fertility issues. And Jacob syndrome, where you have an extra Y chromosome. So these 3, Klinefelter, triple X, and Jacob syndrome, are sex chromosome trisomies. All 3 can be missed by all the screening tests that we do apart from NIPT, and also can be missed during fetal imaging. Next are polyploidy conditions, which the most common is triploidy. This is usually not compatible with life and they tend to miscarry. Tetraploidy, in rare cases, there is 1 case reported of a live birth with tetraploidy, and pregnancy loss is common with these polyploid conditions. Now, when it comes to aneuploidies, chromosomes aneuploidies are divided into 2 further categories. One is a whole chromosome change, that is the monosomy and trisomy we just discussed, they are common. Second are segmental aneuploidies. These are partial losses or gains on the chromosomes. So this can happen de novo and can happen during gametogenesis as well as embryogenesis. The next type of changes are structural changes. Now, structural changes are mainly of 4 types. One is translocations. We call them balanced translocations when the chromosome content is not changing, just chromosomes tend to switch their locations. So this is a transfer of location of the chromosome, so translocation. You can have deletions on the same chromosome, you can have duplications on the chromosome, and you can also have inversions where a part of the chromosome detaches. So there will be 2 breakpoints. It will invert itself and reattach itself. So this is also a balanced condition, but can trigger some abnormalities. So when it comes to translocations, we have two main types of translocations. One is reciprocal translocations and Robertsonian translocations. The difference between the two is in reciprocal translocations, you will get segmental deletions and segmental duplications. So this is partial deletion, partial duplications on the products, that is the babies that the couples can make. And then you have Robertsonian translocation when one whole chromosome moves and sits on another chromosome. This is common in acrocentric chromosomes like 15, 16, 21, 22, etc. Okay. So the difference between these two can only be detected by a test called karyotyping. No level of advanced molecular testing, like you must have heard about microarrays and NGS, none of these tests can detect these translocations when they are in their balanced form. So to know if our apparently healthy looking patients are carriers for these conditions, karyotyping is a test that has to be done. And I always would like to stress on the fact that never skip this test. Any level of genetic testing should start from a karyotyping, and karyotyping should not be skipped for especially fertility related matters. Now, this is a case where we had this couple. They had, she was very young, 31 years of age, primary infertility. So they went for an ART conception. We didn't do any screening. We just went through an IVF cycle, transferred the embryo. The very first pregnancy, there is generalized edema, single umbilical artery, omphalocele. These 3 conditions are indicative of a chromosomal conditions primarily. So first we did, though this is her first pregnancy, but she's gone through IVF. So usually we run the testing after 2 pregnancy losses, but here we tested first pregnancy loss right away. So this, the product of conception chromosomal array showed a typical presentation of a translocation. That means there is a gain and then there is a loss on 2 different chromosomes. So on the 3rd chromosome, there was a duplication of 36 MB, which is called a gain. And on 7th chromosome, there was a loss of 3.5 MB, which is a loss. Now, we have found the reason for the abnormality after the termination, but do we send her away? No. Follow-up testing is very, very important. So we called her back, we gave her counseling, went in for karyotyping, and we found that her husband is a carrier of a translocation between chromosome 3 and 7. So can you see here? This is again chromosome 3 and 7. So the same chromosome translocation is present. If the karyotyping was normal, I can reassure this couple, let's transfer the remaining embryos, no problem. But since this is a translocation, the recurrence risk of this anomaly is extended. Therefore, we need to be careful and counsel the next pregnancy accordingly. I will discuss what are the preventive measures we can do. So these are an example of chromosomal conditions. What about subchromosomal conditions? Now, if we open up the chromosome, it opens into the DNA double helix, and this is divided into segments. So each segment of the chromosome is called a gene. So there are genes which code for a single protein. There are multiple genes that can code for multiple proteins, or multiple genes can code for a single protein. So all these combinations are possible. So we are focused on single gene defects, where a single gene is responsible for a single disease. That means single gene responsible for a single protein. These are very easy to diagnose and prevent. There are second category of diseases called polygenic disorders. They are much more complex, and testing and preventing them is much more complicated, therefore not currently practiced. So if you look at the structure of a gene, you have intercalation between exons and introns. Exon is the coding part and introns is the regulatory subunits. So basically any diseases that happen on the exon will manifest itself. Therefore, most commonly, the collective exons of the genome are called whole exome. If you look at all the exons and the introns of the genome, it's called whole genome. So this is two main things we should remember. What we commonly test is exons, that is whole exome, which are responsible for genetic diseases. So for example, there is a gene called HBB, which is sitting on chromosome number 11, responsible for correct formation of hemoglobin. So any defect on this particular gene can cause two diseases, either sickle cell anemia, which causes sickling of red blood cells, or thalassemia. This is an example for a single gene defect. So when we look at single gene defects also, you have subcategorizations of mutations. Just like you have large deletions, large duplications at the chromosomal level, those are pretty big. Here, you can also have mutations at the code level. So you can have substitutions where a single nucleotide is replaced with a different nucleotide. You can have a loss of a nucleotide. You can have a duplication of a nucleotide. And you can also have a structural change which can structurally change the nucleotides. One second. Yeah. So when we look at these mutations, these are how the mutations manifest themselves. And the American College of Medical Genetics has criteria on how we assess the influence of these mutations. So this is categorized basically into 5 main categories. You have benign and likely benign mutations, which you never see in any reports, because benign means they are not disease causing. So they are not important. They're not going to cause any change to the coding region of the genome or the protein that is formed. So they are not significant. You have likely pathogenic and pathogenic conditions, which are disease causing conditions. So for these two conditions, we can easily offer preventive measures. You have a middle conditions called variants of unknown significance, called VOUS. Now, these variants are categorized this way because of lack of literature. So the entire categorization of these mutations is dependent on databases which are formed from scientific literatures as well as case reports. Now, in variants of unknown significance, these are usually new mutations or very rare mutations where a disease has not been explained or reported. Therefore, the influence of that mutation is unknown. We cannot say that it is disease causing, and we cannot say it is not going to cause the disease. Because of this ambiguity, we usually do not offer interventions for these particular conditions. Now, a second feature of genetic testing is it is not a straightforward test. It's not like I find a mutation and I say this is a normal variant, this is a pathogenic variant. That is not how it works. Mutation categorization is dependent upon what we call phenotype to genotype correlation. You can have many mutations, but if we cannot see any impact, then the category of the mutation gets downgraded. Okay. So for VUS conditions, we can only say that this can change with time. So we need to review the case and the mutation every 1 or 2 years. Or else we have to take a clinical call if there is a strong correlation with the affected child. So if a child is affected and a particular list of the phenomena of a genetic disease is expressed, then it is called a phenotype-genotype match. And if it matches fully, then we take up for intervention as a rare condition. And we also encourage people to publish these cases so that it helps other people in the future. So VUS conditions needs careful correlation from the geneticist side and the clinician side, and then you take a joint decision whether or not you are going to offer an intervention, because there are certain ethical restrictions also. For example, you offer a very expensive intervention or terminate a pregnancy for a VUS now, and then after 2 years turns out it's not a disease causing variant. So we have to live with the conscience of having terminated a possibly healthy child. So for these reasons, VUS conditions, we do not offer any preventive measures. So single gene defects have what we call inheritance patterns. So these inheritance patterns are divided into autosomal recessive, autosomal dominant, and X-linked. So I'll go through each of these one by one. So autosomal recessive conditions are when you have 2 copies of the gene always. Individuals can be a carrier if they're carrying 1 healthy copy and 1 mutated copy. In these genes, the single healthy copy is able to sustain the function of the protein. So therefore, the individual does not manifest the disease. In case both couple are having a mutation on the same gene, that means there is a permutation combination possible. There is a 25% possibility that mutated copies from both parents come into the baby, and therefore the fetus gets affected, or fetus or the child. Then there is a 50% chance of both of the babies being carriers, just like the parents. There could be a 25% probability of complete healthy pregnancy. So what we need to understand is mathematical risk does not equal reproductive risk. Just because we say there is a 25% chance of getting affected, and possibly this 75% set of individuals, either carrier or normal, are not going to manifest the disease. But we have seen recessive conditions where back-to-back 3 to 4 pregnancies can be affected. Therefore, you need to consider it as per embryo risk, not out of 4 embryos, 1 will be affected, 2 will be carriers, 1 will be normal. That's not how it works. Per every embryo has a 1 out of 4 chance of being affected, 2 out of 4 chance of being carrier, and 1 out of 4 chance of being healthy. So this is how we need to assess reproductive risk. So it is entirely possible that all 4 pregnancies consecutively are fertilized by mutation carrying sperm, and the eggs were also mutation carrying eggs, and that therefore all pregnancies can get affected. Another condition is autosomal dominant type of inheritance. Here is what we call strong mutation, to speak in name and language. A single mutation allele can manifest the disease. Here there is a 1 out of 2 chance of the children being affected from a mutation carrying individual when married to an unaffected partner. And there is a 50% chance, 1 out of 2 chance of having healthy children. Even here, the possibility is very high. Every gamete could either be normal or abnormal. So per embryo, it is a risk of 50%. So therefore, the risk is considerably high compared to what we say, out of 100 people, 50 people will get affected. It is not like that. It is out of 2 people, 1 person get affected. It should be explained in that way. Now, when it comes to autosomal dominant conditions, there are 2 main conditions we need to understand. So with autosomal dominant conditions, we have early onset, neonatal onset, and we have late onset. That's one. We have one more phenomena called penetrance. That means every individual who carries the mutation is affected, means it's completely penetrate. Reduced penetrance means there will be individuals in the same family carrying the mutation. It could be entirely possible that some individuals will manifest the disease and some individuals may not manifest the disease. This is called reduced penetrance. Okay, this can explain why a child may be affected with the autosomal dominant condition, and the parents could be carriers but could be apparently healthy. This is because there will be a generation to generation change in the expression of the gene. Second, it's called variable expressivity. Variable expressivity means the same mutation can manifest in different phenotypes across different individuals. Now, what we need to understand is, it's not like one mutation is only going to cause one particular manifestation. One mutation can have multiple manifestations. Therefore, we need an exact clear phenotype. So when we do genetic testing, it is very important to note all the clinical features of an affected child, affected individual, or an affected fetus. Those phenotypes are then fed into a bioinformatics software, and then the mutation gains significance, and that's how we categorize your variant. There is one more feature called gonadal mosaicism. Here, you can have children getting affected, but individual will be healthy. The blood samples will test normal, but there might be that maybe some of the few sperm are carrying a mutation or few eggs are carrying the mutation. So this is a possibility where the child is affected, both parents are healthy, and again another pregnancy is affected with the same disease. So usually there should be a genetic cause, but when the genetic cause is not found, this is for few conditions, this is indicated. So when you're working with genetics and you're working with a good geneticist, we will be able to tell you that with this particular gene, there is germline mosaicism. So here we need to plan preventive measures for the next pregnancy anyway. Now, the most important one is X-linked inheritance. Here, basically, females will be carriers, asymptomatic, and only males will be affected because males don't have the other X chromosome. So, X-linked recessive conditions. Here, we should remember that in the inheritance pattern of X-linked conditions, there is a common misconception that all the males will be affected. That is not the case. Of the male babies the female partner can make, 50% of the male babies can be normal, 50% male babies will be carrier, 50% males will be affected, 50% males can be carrier, normal, and then Among the female babies, you can have carrier female babies and completely healthy female babies. So there is a risk for the male children to be affected. So in case you have a woman who is a carrier of an X-linked condition, please don't ask the fetal medicine the gender of the fetus. That is the wrong way to do it. It is entirely possible that the mutation can be present, and even if it's a male baby. So always do the genetic testing. And the genetic testing will clearly give you information. All the labs will give you the information that the fetus is carrier or the fetus is affected, because we are allowed to disclose that in cases of sex-linked conditions. If the fetus is unaffected, it could be a healthy female or a healthy male. Both possibilities are there, as you can see here. And that is why it will be given as normal, and we won't tell you the gender of the fetus. So in case there is an X-linked condition in the male, that means the male is affected. For example, it could be hemophilia and or G6PD deficiency. So these cases, what happens is the male will be affected. If the female partner is mutation free, then all his female children will be carriers and all the male child will be unaffected. So in these conditions, we do not offer any intervention because there is no risk for any of the children to be affected. Females will be carriers, but they are going to be fine. There is reproductive risk for his daughters, which we can address when they plan their pregnancy, and that will take at least maybe 20 years minimum. And at that time, we might have better technologies to correct these defects. So right now, it is an ethical issue to offer interventions for when there's a male partner carrying a extinct condition. Okay, so male partner with an extinct condition, we ask them to plan pregnancy normally without any interventions. Now, when it comes to type of genetic disorders, they are extremely diverse. So we saw chromosomal conditions, deletions, duplications, inversions. We saw mutations, and within mutations, you have nucleotide deletions, nucleotide duplications. We also have what we call repeat expansion disorders. Certain conditions, like the most common we know is Fragile X, right? So we have CGG repeats, and this keeps changing. So based on these things, there could be changes. You have also epigenetic conditions and polygenic disorders. Why am I saying this? Genetic conditions are diverse. So the testing portfolio for these genetic conditions are also diverse. There is no one single genetic test that can cover all the conditions that are mentioned or assess risk for all the disease for an individual. So that is why when it comes to genetic testing, we go disease-wise, manifestation-wise, suspicion-wise. So if we know what exactly the variant is, a child is affected, we know the mutation. You want to just confirm the variant, do a targeted testing in the parents, we go for Sanger sequence. If we don't know what the mutation is, we just know that it is a disease, say it is thalassemia, or there's the neonatal demise, or the baby is not able to maybe speak or hear, there could be deafness or mutism. For those conditions, based on the phenotype, we can look at either gene panels or clinical exomes or whole exomes. So gene panel will be a short list of genes associated with the typical condition. So if you're looking at, say, retinitis pigmentosa, there are some 16 genes involved. So you will have a 16 gene panel or a 48 gene panel. If we are looking at, say, a very generalized information, that there was a neonatal demise, child was in ICU, there was a metabolic distress, and the child expired. So yes, there is a suspicion of a metabolic disorder, but we don't really know. There are so many metabolic disorders, which are usually inside a clinical exome or an inborn error of metabolism panel. So we can choose either. And if there is a diverse phenotype, say 2-3 pregnancies with different kind of phenotypes, then we go for a comprehensive approach with the whole exome sequencing. Now, if we know for a specific disease, like we know it is Duchenne muscular dystrophy or spinal muscular atrophy, this is gene-specific deletion duplication analysis called MMPA. Now, this next generation sequencing or Sanger cannot diagnose these two diseases. If you run these two tests, we will not find this diagnosis. So specifically based on the condition, we choose when we want to do MLPA. MLPA is also a second tier testing, in the sense we do a mutation screening and we're suspecting a deletion duplication at a gene level, we go for MLPA. Okay. The microarray does not work at this level. The microarray works at a different level. So these are large exonic deviations. Then you have, for repeat expansion disorders, you have TPPCR. So we have multiple repeat expansion disorders, not just Fragile X. We have Huntington's disease, spinal cerebellar ataxia, which all come under these diseases. So if I would do just a karyotyping, I would not diagnose all these many diseases. If I do just NGS, I will miss out the other two. So it is not possible to go with one single test for all. And this is very, very important because the patients tend to get frustrated that why are we doing so many tests? So when we offer genetic testing, we inform the patient that this is not a one-step solution. There could be multiple steps to the diagnostic process. Now, are these genetic conditions rare? So most of you may have come across Down syndrome, but not other conditions. But no, genetic disorders are not as rare as we think, mainly because now the accessibility to genetic testing has considerably increased in the past 10 years. And there is almost a 400 times additional information that is getting generated and diagnosed. If you just see a tiny European population, which is probably a city of India, 1 out of 12 people carry these conditions. And there are over 7,000 rare conditions. Only 5% of these conditions have therapies, and these therapies are extremely expensive. And therefore, it is very, very difficult to manage these conditions. So for these conditions, prevention is better than cure. So what are the most common genetic diseases we come across in our country? Thalassemia. Everybody knows about thalassemia. It is very easy to diagnose it because we do what we call a HB electrophoresis, which is a biochemical test, very economical. But there are other conditions beyond thalassemia. Most important is SMA, spinal muscular atrophy. Now, this condition has a carrier frequency of 1 out of 38. In India, again, its carrier frequency is 3 to 4%, same as that of thalassemia. So right now, when we offer screening tests, the SMA is always included. SMA is not done with NGS, it is done with MLPA. So you need to separately order it apart from your regular exome sequencing. You have DMD, which affects 1 out of 3,500 male births in India. You have inborn errors of metabolism that affect 1 out of 2,500 children born. You have cystic fibrosis, which is much rarer in India, 1 out of 45,000 almost, or to 1 out of 1 lakh. And then you have Fragile X, which is 1 out of 215. So coming to the next stage, the reason I explained about all these disorders is we are going to discuss about carrier screening. So what is carrier screening? Why should we do all carrier screening? So carrier screening is a test which is used to identify asymptomatic individuals or couples who might be at a risk of an autosomal recessive or an X-linked disease. Now we discussed about the inheritance patterns. We spoke about autosomal recessive, autosomal dominant, and X-linked conditions. Now, why have I left autosomal dominant here? Because autosomal dominant conditions will manifest themselves. You won't have unsuspecting individuals. There will always be history. Based on that history, we can do the requisite test. That's a focused approach. Carrier screening is offered to couples who are completely asymptomatic. It can be offered to couples with no history at all also. Because individuals can be completely healthy but carrier of these conditions, and there is a risk of their children being affected. Unfortunately, unless a child is affected with these conditions, there is no way to diagnose this. There are so many people who come to us with children affected with autosomal recessive conditions saying, we have no family history. This is never heard of in our family. So that is why carrier screening is now becoming popular. So what is a carrier? A carrier typically means a healthy individual who is not affected with the condition, but can pass the variant to their children and with the risk of possibly affecting their child when the partner is also carrying a same mutation. Now, everybody thinks autosomal recessive condition, wife has a mutation, husband has a mutation, and this mutation should be the same for the disease to manifest. That is not the case. The function of the gene is affected with the entire gene region. That means it is possible that in a particular gene, the wife might be having a mutation on location 50, and the husband could be having a mutation on location 128. Either case, both the alleles are defective, and we call this compound heterozygous condition. If it comes together to the fetus is going to be affected. So if you're looking at mutations, you need to understand that it's not about the same mutation. People can have different mutations, and separate tests can be ordered for this. It can also be possible that wife has a mutation, husband has a deletion on the same gene. Same impact for autosomal recessive condition. So genetic conditions are heterogeneous in all ways. So when do we offer carrier screening? Carrier screening can be offered before planning a pregnancy. We call it preconception carrier screening. We can also offer it before planning an IVF cycle because an ART cycle is expensive. And it is very disheartening to see that we go through all this process of generating good embryos, getting a pregnancy, and then the child is affected with a genetic disease. So two couples who are willing, carrier screening can be offered before the IVF cycle. It can also be offered to couples who are planning a pregnancy, so or a donor pregnancy. So we offer genetic test screening for the donors as well. What is an important feature is when should this test be ordered? What are the indications? First of all, a previous child affected with a genetic disorder is a big indication for couple carrier screening. Consanguinity, second degree, third degree consanguinity, fourth degree consanguinity, you can still offer the testing. The degree, as the degree of consanguinity is closer, that means from 4 to 3, 3 to 2, the possibility of finding common diseases, common disorders increases. Any family history of genetic disorder, always ask, have they had history of babies being born and dying immediately? We call this neonatal demise, but patients don't often open up about all these things, especially neonatal demise. Anybody with the disability to hear or speak or any kind of physical deformity, all of them fall under this category. You can also offer it to patients who are going for donors. So how do we work with donors? Now, to work with donors, you should always order the test in as a duos carrier screen, which means the intending biological parent and the donor has to be screened. Whether it's an egg donor or a sperm donor, it doesn't matter. Right? If you're offering carrier screening, you need to offer it as a couple testing. That's when it has impact, because all of us are carriers of at least 2 to 3 mutations. So if I do, for example, a donor carrier screening for an egg donor, I'm always going to find 3 autosomal recessive conditions. Then we have to worry, is the male the carrier or not? It's an ambiguous question. Another 4 weeks goes to complete the diagnosis of the male partner, hence delaying the entire process. So it's always beneficial to screen the donor and the intending biological parent at the same time. Okay, so how does the carrier screening process work? We always offer genetic carrier screening. Pre-test counseling should be offered before a carrier screening process, because this is a screening tool. We are not going to eliminate all the genetic conditions based on one carrier screening test. So a proper genetic counseling has to be offered, what this test can or cannot cover. It should not be that we have not offered this. There is a genetic report putting the patient at low risk. We are not planning any intervention, and then suddenly some disorder manifests itself. So we need the patient to understand the risks, the advantages, the limitations of a carrier screening test. Based on the pre-test counseling, a genetic counselor will collect all the previous clinical history, any kind of detailed questions that need to be asked, whether it is cancer, related, unrelated, and a detailed pedigree is done. When we get all this information, then the carrier screening is informative. If you just tell us, this is a secondary consanguineous couple, we want to do carrier screening, it is a very superficial version of the test, and we won't be able to give you informative results without the phenotype and the clinical history missing. So therefore, a pre-test genetic counselor has 2 advantages. We'll get the clinical history also, and we will also explain to the patient the risk versus benefits, so that they can understand what test they are choosing based on their affordability and interests. And then we can easily do a post-test counseling once the results are available. So the genetic test is always sandwiched between a pre-test and a post-test. Sometimes during the post-test, we might have some indications during the carrier screening which requires a second-time confirmation. There are certain ambiguous results also, because of which a post-test counseling is very, very important. And then we will offer the interventions that can be planned for this. So just for your information, the highly prevalent tests, which are cases, diseases that I've already discussed, is beta thalassemia, sickle cell anemia, cystic fibrosis, Duchenne muscular dystrophy, spinal muscular atrophy. You can add on karyotyping, because as I said, these tests are basically NGS based, so karyotyping is separate. The sample also is separate. So it can be add on if they want to. This first thing. Every company has a different sets of carrier screening panels. So they will have different names. So they could be a focused panel of say 450 genes, and there could be a focus panel of 450 genes. SMA and DMD is separate add-ons. There could be another 2000 genes panel. These gene panels are usually NGS based. Okay, so there could be a 2000 gene panel. SMA and DMD is separate. Again, if you go for a more comprehensive screening. Then it will be a whole exome with SMA and DND. So here you have the possibility of having some unknown, unexpected findings. There will be a long list of genetic diseases which the patient can be a carrier for with whole exome. So ACLG basically suggests a shorter gene panel of 450 to 2000 genes, but then we have to work according to the mindset of Indian patients, and they would like, in our experience, usually they prefer higher coverage. So case to case basis, we can offer the counseling and take it up. So this was a case of a preconception carrier screening. This couple were from a tribal place in Madhya Pradesh. This male partner was a teacher, and he is affected with sickle cell anemia, he told us, and his sister is also affected with sickle cell anemia, and his female partner is a carrier for sickle cell anemia. So since he's a teacher, he's pretty educated, so he knows this. He got an HB electrophoresis already done for his wife. So, but he told me that he's affected with sickle cell. He's not very symptomatic. He's had only 2 transfusions in his life. So ideally, instead of going for a targeted approach, when the patients come to us with just an HB electrophoresis report with this kind of history, we go for what we call an HBB full gene sequencing testing. Okay, so you can do either a direct mutation testing for only sickle cell anemia, because there's only one mutation for sickle cell anemia. But what happens is, if there is a different mutation in the background, you will not know and it will get missed. So ideally, when there is an HB electrophoresis carrier report which is saying positive for carrier or positive for trait, go for a HBB full gene sequencing. Don't cut costs and go for a smaller hotspot panel, because the incidence of rare variants is present. So full gene sequencing will give a one-shot clarity what is going on. So the female partner, as expected, was a carrier for sickle cell anemia. The male partner had a sickle cell mutation and a thalassemia mutation also on the intron. So this intronic variant is a common thalassemia variant. So because this is what we call a sickle beta thalassemia disease, it's a milder version of thalassemia. So very few transfusions are required. Now the risk calculation completely changed based on this report. If I go by his history, there was 25% risk, but now there is a 50% risk because he has one more mutation sitting over here. This couple then went for PGT-M, that is mutation testing in the embryos, because they were planning IVF and he didn't want to go through any terminations. So we went ahead with that and then they conceived. This was a case of a couple actually, sorry, it is wrongly typed, it's not donors screening. This couple is basically fourth degree consanguineous couple. And here they had a history of their second born female child who presented with certain skin complaints, developmental delay. Luckily, the genetic testing was done and a homozygous pathogenic mutation on this particular XPC gene was diagnosed in the affected child itself. So the child was diagnosed with xenoderma pigmentosum group C. This is an autosomal recessive condition. Baby succumbed at 6 years of age. They have one healthy son who's completely fine, 9 years of age, healthy. So here we had 2 choices. Either we go for a targeted approach for this gene, focused on this, but the couple, she's already 38 years old, so she didn't want to take any more risks. So they decided to go for a comprehensive panel. So we went for a whole exome sequencing, because here there's a mutation risk only, no other diseases. We found that both the couple are a carrier of the mutation that has manifested in the child. So you should note that there are 4th degree consanguineous couple. Usually we don't expect the risk of a disease, but then the child is affected, so the risk increases. And he was found to have, the male partner was found to have 3 other mutations, which are all autosomal recessive conditions. Female partner is not a carrier. So though this is all red and patients tend to worry about it. So since it is autosomal recessive, female partner is not a carrier for these 3 conditions, we need not worry about these 3 conditions. There is no risk for this. The risk is only for the condition present in both the parents. So this is how couple carrier screening works. Simultaneous testing for both the couple, and you will get a side-by-side comparison, which is extremely easy to understand. So this is a case of a breast cancer screening. So the reason I put this case is, there is a lot of awareness about breast cancer, and everybody knows breast and ovarian cancer is pretty common. The main culprit behind it is BRCA1 and 2 mutations. So everyone is ordering BRCA1 and 2 mutation testing. It is economical right now. It's great. It's great that the pickup rate of the test is so good. But what happened was, this was a 38-year-old woman. Her mother expired at the age of 52 due to CA breast. Her grandmother had ovarian CA. She has 2 daughters and a son. So during her testing, the germline testing was not done at that time. So she was concerned, and therefore she came to us saying that let's do the testing. So if we had chosen only a BRCA1 and 2 mutation, it would have come negative. And most people, because of doing BRCA1 and 2 mutation, say, oh, it is normal, there's nothing to worry, and just send the patient back. What we need to realize is there are other genes responsible for the same cohort. So there are almost 12 genes inserted in this breast and ovarian cancer hereditary gene panel alone. So this patient had actually a BRD1 mutation. It's a dominant mutation, likely pathogenic. So dominant mutation means it can be late onset, it can be having could be 50% of her children can be affected carrying the mutation, and could be 50% children are not carrying the mutation, but all her 3 kids are asymptomatic right now because they are on the younger side. Now, what to do next? The next step is also always to test her children and to test all her children, not just the daughters. You should need to test even the son. You would say, why there is only risk of breast and ovarian cancer with this gene? Why should I test the son? It is a common misconception that breast cancer affects only women. So almost if BRCA1 mutation affects 50 to 65% of women with breast cancer, there are still males with breast cancer with 1.2%, BRCA2 up to 9%. In BRCA1 and 2 mutations are also indicated in pancreatic cancer, ovarian cancer, prostate cancer. So BRCA mutation can increase the risk of prostate lifetime prostate cancer risk of a male patient to 9% and BRCA2 mutation at 15%. So men should be tested. So some myths I wanted to bust with this is BRCA mutations can manifest as other cancers also. Men with family history of breast cancer should undergo testing, because if he's going to pass the gene to a female child, there is a 50% possibility she might have early onset breast cancer. There is 80% possibility of manifesting breast cancer if we are mutation carriers. BRCA mutation is not for women alone. And BRCA does not manifest as only mutations. So there are deletions and duplications. So if the BRCA1 and 2 mutation has come negative, you need to first go for an extended mutation panel and second go for a deletion duplication panel for BRCA. So it's a 3-tier testing. Instead of this, you can go for a hereditary cancer panel, which will look at all the mutations in one go, and a reflex testing. If it comes normal, we can go for the deletion duplication testing. So just to reiterate the fact that one type of testing cannot diagnose the entire disorder. So breast cancer does not mean BRCA mutations alone. Go for a full panel instead of spending only on BRCA1 mutation, then going for other cases. So just let me just stop sharing because I'm going into the next one, but I need to get rid of these lines. Sindhuja, can you help me with this?
I'm also trying actually. I don't know how to do it. Pouncer, can you? It in the lines. Can you? Okay.
No, I just stopped sharing and I'll share again.
Okay.
Okay, done. It's gone.
That's what I've been trying to do for the past 10 minutes since it came up. I don't know how to do it. So sorry.
Okay. No worries.
Shall I call the admin?
No,
It's
ma'am.
gone
It's
now, ma'am. It's gone. There were lines. Somebody.
Can we just pause for 5 minutes and do the 5 FAQs so that you can take a voice break? Or you're going to finish now?
No, ma'am. There is another half.
Can we just take five questions, 5 minutes break? Yeah.
Yeah.
Sindhu?
Yes. So we just, I've just started a poll. I request you all to participate in the quiz. So the answers are anonymous. It's just to see how much you're able to follow, and if you have any doubts, you can clarify it with Fiona. You know what? Actually, every time after I attend a session of yours, I'll feel like I know so much in genetics. Because you make it very simple and very clear. Although
Actually, this is
it's
such a
very
complex topic. To
subject.
be very honest, the way you put the practical case scenarios and everything, it is so relatable actually to your day-to-day practice. One thing which you were talking about, this VOUS, my thing is, of course, you cannot offer diagnostics, or you cannot say that, whether the child will be affected or not for sure, and you cannot offer any testing platforms. So how do you, take this in terms of counseling the patients? Like, what to do? How do we actually counsel the patients?
Ma'am, first thing in VOUS is we have to evaluate the variant. Second thing, we do a phenotype to genotype correlation. Is it a perfect match or if it's a partial match? If it's a full match, then the possibility of us offering interventions is high. Second, we also go through literature survey at the background to see if there are any cases reported with similar manifestations. So the literature workup is also done. We look at how the protein is getting affected and is it detrimental to the protein function or not. So based on that, we'll get some idea. The third step is to identify if the VU is inherited or de novo. So there are two types, right? It can happen for the very first time in that particular case and the parents will be normal. So once the affected child is diagnosed, parental testing is mandatory. So we know it is present in the parents. Then we look at family history. Is there anybody else in the family manifesting similarly? So in consanguous couples, it's a little more, there is a possibility of finding this information. Non-consanguous couples, two different mutations coming together, VUS, it's very, very difficult. Then we only rely on clinical correlation. So if it's correlating clinically, then we give special consents to the patients to help them properly understand the risks and limitations that honestly, we don't really know the impact of this variant. So once that is very clear, the patient signs and understands that this is the case, then we can offer the intervention. So there is no law preventing us from offering the intervention, but as now we follow only clinically relevant conditions, right? So based on the clinical evidence, we can take it up, no problem.
So we are talking about genetics and infertility. So just for understanding for all of us, at what point we should offer genetic testing, whether it is a basic karyotyping or anything, in a couple who is approaching us for infertility treatment. For example, they've gone through multiple cycles of IUI and it's just unexplained infertility and they have to move on to ART, or they're having some sort of repetitive IVF failures, or patients even with endometriosis, PCOS. A lot of genetics are playing into all these points, right? So I wanted your inputs on that. Like, when should we really order genetic tests in patients?
So in the next, in the fourth segment of this talk, I have included male and female infertility indications, first thing.
Sure.
Second thing, basic karyotyping can be offered to everyone because it is affordable and it's better to be on the safer side with that. Now, we have to be careful while offering advanced genetic testing because they're expensive. So two main categories how we choose our patients is, A, is there a family history? Then yes. Then second, based on the intervention. So if you're planning to put the patient on some strong intervention, irrespective of the condition. For example, we have certain male infertility mutations which cause teratospermia. I have that in my talk. So in case there is a genetic mutation, lifestyle modifications and medications are not going to change the situation. So we can take a clinical call directly instead of putting the patient through all of that. But if you're any which way planning to proceed without all of these things, directly planning for an ICSI, then you don't need to do the test. But the patient should understand there is a possibility that even their children can have the same infertility issue. So based on the manifestation, we take the call on case-to-case basis. So generally, when for infertility, routine karyotyping is what we offer. Then it is based on the phenotype and how. For example, POI. If you are any which way planning a donor egg pregnancy, then you don't need to run any test for the individual. But if the individual is insistent on a cell cycle, if you have very few follicles, one or two, and you're still planning a testing, then testing is important because in case if it is Fragile X, it is rare, but in case if it is Fragile X, then she has an idea that there is a risk for the son to be affected. So she can choose for a donor egg and avoid all this intervention. So that way we take a call.
That's very nice. See, with regarding to the karyotyping, now, many times in my practice also, and I think many of us who are practicing fertility would have observed that they come with a karyotyping report, right? So in certain scenarios, I have repeated the karyotype and then, a normal karyotype has become an abnormal karyotype. So, I understand the importance of the good lab and the reporting standardization and everything. But for us, who are not into this routine field, how do we identify and what should we really look in karyotyping report? And when we should think of, doing a repeat karyotype, because it amounts to added cost to the couple. And it is very difficult at that point to tell them to repeat a karyotyping test.
Yes. So there are two main abnormalities we use to identify in karyotyping. First is the translocation. So most of the standards labs should be able to pick up the translocation, because karyotyping is a culture-based test. Then it is completely automated. There's an AI-driven software which automatically screens about 300 metaphases. This is how we do it in our lab. So first there's an automated karyotyping done, then a manual karyotyping is done by the cytogeneticist. So what happens is, the risk is, if the translocation is large enough, now karyotyping at the standard 450 bandwidth is what we do, 450 to 500. We can pick up translocations down to 5 MB size. Now, if the translocation is terminal, that means telomeric regions, end regions of the chromosomes are done, it can get missed. So that is a manual process. It depends on the cytogeneticist itself. So there is nothing we can do about that. If there is a constant pregnancy loss, then maybe we should reconsider. That's one thing. If it's large enough translocation, there is, once a lab has reported a translocation, it cannot be a false positive. You have a clinical history of pregnancy loss, no need to repeat it. Third one is these polymorphic segments that you find, 14 PS plus, 15 PS plus, YQH minus, 1 PS plus. This is a complete manual call. It depends upon the condensation and decondensation of the chromosomes. We have multiple cases where one lab has reported it normal, one lab has reported the polymorphism. Even in our case, it has happened that another lab has reported the polymorphism, we have not, or vice versa. So this is a complete manual call. I had a detailed discussion with our cytogenetics team for this. And what they tell us is, A, these are not clinically significant, first of all. We have to interpret them with the history of pregnancy loss. If there's a history of pregnancy loss, then we plan intervention, because it could be a chromosomal imbalance that can be triggered by it. There is a possibility, conflicting evidences are present. In either case, I don't think repeating it is going to give any information. The same case. Especially for polymorphic segments, please don't repeat it. Nothing is going to change, ma'am. Even if it comes normal, then counseling the patient becomes more difficult. So that is one way.
You report what standardized thing we should always look for. Definitely the images of the chromosomes that they're going to give.
Always.
Always.
We always rely on the karyotype image that is reported. Never go for just reports without the karyogram. That is important, because if it is very blur and if it is not a good quality karyogram, you already know that maybe the test is not being performed optimally. You can either ask the same lab to repeat it free of cost, because then it's a lab issue, right? So we have to do a repeat testing, or ask them to give you images. We may minimum 5 metaphases are karyotyped, so those images are available. So we can ask for that instead of making the patient spend. Ask the same lab to repeat it. Second, if there is a constant pregnancy loss, you are finding very small deletions, say on a microarray, and you have a feeling that this is consistent, it is a karyotype issue, then the routine karyotyping may not suffice to pick this up. So you need to go for a higher resolution karyotyping. We call it whole chromosome painting. It's called sky karyotyping. It is done by only one lab in Bangalore, I think, in India. It's very good, because it will look at all the chromosomes in color, not black and white. So if there is a small translocation also, the test is able to pick it up. It is like if your routine karyotyping is X cost, that is 4X cost, which is 4 times more expensive. But for these cases where you suspect recurrent pregnancy loss, chromosomal causes identified as a very small deletion duplication, definitely it will be able to.
And as you were mentioning about the SMA and DMD and beta thalassemia, I think in Indian scenario, we should incorporate it as part of our screening protocol. What do you say? And is it really very expensive to do it? And do you think it is wiser to do all this for our couples who consult?
Well, yes, I mean, for thalassemia, it's pretty easy, because we have a bedside HB electrophoresis, which is very economical. The report comes within a day or two. So that is good. It has to be done for all couples, especially in the West and North, where there's a belt, it's constantly done. But we can also do that as part of our screening, because prevention is better than cure, if you ask me. Biased because of my profession, because we only see genetic condition. So for us, it is not rare. But from a clinical perspective, it might be rare. It's an additional cost, but not very expensive. SMA, if a couple is planning an IVF cycle and they're concerned about genetic disorders, we can offer it. The testing costs roughly about maybe 10,000-12,000 to the patient. So it's not that expensive. If they're considering, they can do it, because we have had cases where the patient had a history of child affected with SMA. In that case, You have to do it. In case they're going for donor, mandatory the donor has to be screened for SMA. That cannot be skipped, because we have had at least 4 cases of donor pregnancy where the couple had a history of SMA, and again with the donor pregnancy also the child was affected. We have some questions.
Take the questions also on the chat box and also reveal the answers to the poll questions.
Yes, ma'am. So I think there is one question. Procedure for disclosing gender in case of sex-linked disorders.
Okay, so PCPLT has a provision to reveal the gender in case it's a sex-linked disorder on paper. None of us take that risk. Okay, especially if most of the genetics lab that I know don't take that risk. We rely on the genetic diagnosis of the disease. We can tell you, yes, it is a child is affected. So in X-linked condition, when we say the child is affected, it means the child is male. So we don't need any special regulatory approval because it's already there in the law, right? When we say the child is unaffected, that means it is what we call homozygous wild type. Okay, it could be either a male and female. We are well within our limits. We are not revealing the gender. So female child alone, there is a possibility of a carrier, and that can be reported as a carrier unaffected. Carrier unaffected is what we report, and that will inevitably mean it's a female child. And definitely right now the laws are very strict. You can't go terminate the pregnancy. It is unfair to terminate the pregnancy for a carrier individual for an X-linked condition, because they are going to be fined. The disease hardly ever manifests itself. There is only a 0.5 possibility. There is, if it is 0.5 to 1% risk, there is more higher risk of a cardiac event than the genetic disease. So it is not warranted to terminate pregnancy for carrier individuals. So therefore, clinically, it has to be handled in a very strong standpoint. If it is IVF, there the situation completely changes, because prenatal testing, these are the options, right? The baby is already here, we are testing it, and we have feasibility law is solid. When it comes to IVF, we are going for a preventive testing. We will go for what we call PGTM. PGTM is a very, very expensive process. IVF cost, PGTM cost, there are, and the sensitivity accuracy of the test is 98%. Now, why we offer such an expensive intervention, and especially if it is an X-linked condition, if the female partner is a carrier, we can proceed with the PGTM, no issues, because we are going to report to you affected and unaffected babies. That's fine. We can go ahead because we are preventing the disease. If the male partner is a carrier, there is no risk of the disease being affected. We will not offer a PGTM. In case the patient still insists, because the patient knows, nowadays they go through ChatGPT and everyone, they know that only the females will be carriers and males will be healthy. So it's an indirect gender selection. There is a provision in PCPLT. However, it's better to go get a court order, not a lawyer's opinion. Because lawyers will say we can proceed, but lawyers are only going to defend us when the case comes through. And the court of law is the only place where we have a proper decree. So they can approach the court, put forward their case, and if the court gives an order, then we can proceed. No issues. So preferably go through the legal route for X-linked condition when the male is affected. Because things like hemophilia, if the male is affected, he's been able to live his life. There are medications to handle the situation. So these are all things that will interfere in the possibility of eliminating a pregnancy. So legal framework is important in X-linked conditions. We are very careful about that.
See, one more thing which you mentioned about this BRCA testing, where it's quite interesting because most of us only know BRCA 1 and 2, and the entire panel, and you showed that the other one was pathogenic and autosomal dominant, and the importance of testing both the man and the woman. Now, I had a patient, whose mother is a known case of breast cancer. She's undergoing, chemotherapy after surgery. And also, the mother's sister is also having breast cancer and, succumbed to that cancer. Now, this particular patient has come to us for ART. So we did involve genetic counseling. We did offer BRCA testing. But then, because of cost constraints and also fear of, the result of what it could be, they opted out of testing. So we just had to just document it. What if we had tested and we had found some, mutations in it, and the couple is going for ART? What could have we done in that situation?
Actually, ma'am, there are a set of guidelines called MCCN guidelines. We follow that for oncogenetics. And in there, we have certain genes for which preventive conditions like prenatal testing and PGT is allowed. And BRCA1 mutation, BRCA2 mutations are one of those conditions. So based on that indication, we can counsel because the lifetime risk of breast cancer is 80%, which is pretty high. So, and it usually what happens is there will be earlier onset. As the generations go forward, we are seeing a very early onsets, like in their 40s, then it comes to 30s. So in these cases, preventive measures are allowed. In fact, we have done PGTM for cases of BRCA1 and BRCA2 mutations. It is allowed. You don't need special regulatory approval also. It's a pathogenic mutation. So definitely we can offer it. Yeah, it is a late onset condition. So the patients, if they choose to prevent it, we can absolutely prevent it with PGTM. But what we have observed is, first of all, the challenge is there's a concept of pseudogenes where there is an identical sequence in the second gene. So BRCA1 and 2 is like that. So BRCA2 is a pseudogene of BRCA1. They have identical sequences. So the routine testing is difficult. We have to go through certain advanced options that makes the test expensive. It cannot be done by a regular Sanger sequencing in the embryos, especially. Not in the blood samples, the Sanger sequencing works, but in the embryos, it becomes tricky. So it becomes expensive. And we have got very few number of oocytes also in those cases. Either they will be going for fertility preservation, or if there's a history and the patient is not affected, they want to prevent in the next generation. All those things come in. But if it's a breast cancer affected individual just going for treatment, the number of embryos we get are very low. And since it is a dominant condition, the risk of having affected embryos is higher. So that means the possibilities of getting a transferable embryo reduces. So we have to consider all of this and then
Thank
offer
you so
it.
much, Fiona. I think now I will request Sindhu to take the poll answers, and I think we will do a part 2 session on male and female infertility testing and also, genetics, because this is a vast topic, and the masterclass idea is to, cover specific topic completely. So we don't want to do a half hour. It's already 8:45 and all our participants are quite, and you also might be quite exhausted, and we have a whole lot of questions to ask you more and more. So I think we will do a part 2 session on this, and I would request you to please give your convenient date. We will mutually discuss and we will do a part 2 soon. Okay. And Sindhu, can you please take the poll questions, please?
So the first question was, what is the inheritance pattern of DM-deduction muscular dystrophy, which may be detected in the carrier screening? The correct answer is X-linked recessive. 59% have answered it correctly. So the others who haven't, please make note. And which region of the Y chromosome is most important for spermatogenesis? So the correct answer is AZF. So only 36% have said it. Most of them have said SRY. So please.
So I've not covered that yet. So
Okay. So that's like a pre-test for the next session.
yeah.
So which chromosomal abnormality is a well-known cause of female infertility due to gonadal dysgenesis? The correct answer is Turner's, and 78% have answered it correctly. Which of the following is not a commonly recommended genetic test for an infertile couple? The correct answer is hemoglobin electrophoresis. 47% have answered it correctly. And which is the first line of genetic testing considered in couples with recurrent pregnancy loss? Majority have answered it correctly, that it's karyotyping. Thank you for giving the questions, Fiona.
One last question is there. She's asked when to consider couple whole exome sequencing.
So I think I will say a family history, a detailed family history. Anybody in the family with, say, blindness. We had a case of night blindness which picked up a mutation, mutism, deafness, congenital anomalies, definitely. Anybody, we ask these questions to patients usually. Anybody in the family with any kind of mental disability, anybody with autism, if there is any disability in walking, and neonatal demise. Any babies which have mysteriously died within the first 5 to 6 months or within the first few days of birth, for any anomalous fetuses. So ideally, the testing is done for the anomalous fetus first. We can cover that. I mean, I was not able to cover it this time. The next session will start with this preventive options alone. I have workflows that I will discuss with you. So all these are strong indications for a couple whole exome sequencing. recurrent pregnancy loss in the first trimester without any phenotype is not an indication. I want to stress where whole exome is not informative. It is still on research basis. There are new mutations getting described. But right now, in my 10 years of experience seeing mutation screening for first trimester RPL, I have not found any significant answer. Honest answer. You are wasting your money doing whole exome sequencing, or what happens is we do couple whole exome sequencing, we find autosomal recessive carrier mutation in both the couple, and then the focus shifts to PGTM and everybody forgets about the pregnancy loss. So because the patients see the red line, they do not correlate that it's a different disease and it is not cause of pregnancy loss. So this is a common misconception that happens. So whole exome sequencing is not informative for RPL or RIF. It is informative when there is a risk of a genetic mutation and either one of the couple is manifesting any of this, maybe nystagmus, or we had a couple who were very short, both of them, unusually short. So for these cases, it makes sense. But if there is no clear phenotype, then doing the test also is not informative for the couple. It's not useful. So when we're spending so much of money, they will spend at least 50,000-60,000. There should be information that is relevant coming out of the test map. So in my opinion, it should be offered only when these
Is there any
categories
use in offering this whole exome sequencing in a couple who has had failed euploid embryo transfers?
Not really, because failed euploid embryo transfers could be like, let's rule out PGTA because that's very common. Everybody thinks of that the minute there's a this thing. It's already tested. You have epigenetic causes which whole exome cannot tell you. You have DNA fragmentation which whole exome will not tell you. PGTA also will not tell you. Then you have other transcriptomic factors. Again, whole exome is not going to be informative. So no, in RIF with euploid embryo failure, whole exome is not informative. Don't do it. You will have better luck with immunogenetic testing, which is upcoming field now. Probably ma'am will organize another session on that with the experts, but that is probably more informative because we have clinical interventions in place. With whole exome sequencing, you will probably, the idea with whole exome is we need to find a pathogenic or a likely pathogenic mutation. That is our focus as the genetic side. So if we find that, the next option is to either give you PGTM or preventive genetics, both of which are exclusively dependent on the embryo implanting. If the embryo is not going to implant, which is a primary problem, this will not be informative. So no whole exome for RAF or even implant euploid failure.
No, we are trying to find out if something, some answers we get for a euploid. We are so helpless when a euploid embryo transfer fails.
I'm sorry, like my opinion is we need to, like from your clinical side, you need to know when to order the test. But from my side, I feel it's a responsible thing to do to tell people when not to order the test.
Absolutely, because that's very important.
Important,
Thank you
yes.
so much, Fiona, and thank you, Sindhuja. Thank you, all the delegates, for being here with us for over an hour now. So we will definitely come back with part 2 of this genetics program. It was extremely useful for all of us, and we definitely suggest that you share your feedback with us, and we will definitely be in touch. Thank you so much, Fiona, for accepting and being a part of this Scale Masterclass series. We really appreciate it. Thank you so much.
Thank you, Fiona. Thank you. Thank you, ma'am. Thank you to all the delegates.